I'm going to welcome Andrea Ibbison and let Andrea introduce herself and then talk to you about a presentation around Hesley Group. Thanks, Andrea.
Oh, thanks, Kitty. Hi, everybody. Thank you for inviting me today. I've come from Doncaster today, so not too far. So I'm going to just share my slides and get those up for you. Hopefully you'll be able to see them shortly.
We can see him, Andrea.
Okay, smashing. Thank you. So I'll start the slideshow, but just to sort of introduce myself, I've got. So Nikki, just confirm. It says on the agenda that it says 10 to 4 for finishing for me. Is that round about the right time?
Yeah, Sue. Dr. Ben Bowers is due to start at 10 to. Yeah.
No, that's fine. I know what it's like. The pressures of going over, so I'll make sure I don't go over. So my name's Andrea Ibbison, for those who don't know me, and my title's on the screen. And I guess for you guys today, the only title you need to really worry about is the fact that I'm the designated nurse for safeguarding children and children in care over at Doncaster Place as part of NHS South Yorkshire ICB, and I work alongside Kitty and Nikki and other colleagues from the ICB over across the region. So I've come to talk to you today around children in care. So our children safe in care or in harm's way, and this is comes from my experience as I've worked with the Hesley Group and the complex case investigation, which you're quite likely to be aware of because it is pretty much on all our doorsteps over at Dennerby. So I'm going to go through that, and I'm going to go through the learning and how it sort of makes us think about how in primary care as well as in other care, how we can think about our children that are coming to see us on a daily basis that are in care and what's happening. Now, I'm mindful that it can hold some emotional sorts of thoughts for everybody. So please, if you do feel you need any questions or anything afterwards or any discussions, I'm more than happy for anybody to contact me to talk further, and you'll obviously have support with the people that are around this screen as well, but please don't sit on a worry. Let's talk about it. And I believe that you're able to ask questions along the way from what I understand. Nikki or Kitty, if you need to shout out and ask questions, feel free to stop me. Okay, so smashing. So hopefully you will see, just bear with me, my slides moving, which they're not, just bear with me. Oh, there we go. So that's it. So you should see the second slide there. So this is the context really, and I think what you probably know working out there in the previous years gone by, recent years, we know that our looked after children's population is increasing, and it's increasing year on year. And around in England and Wales in about 2022, we thought we looked to have 89,000 children in care, which is a staggering amount of children really. And when we think about children in care, we're not just thinking about foster placements or children residential. They can be in care for in many settings really that we to think about, such as secure children's home and youth offending institutions. They come into the looked after, and also hospital settings. So if we have a child that remains in hospital more than 100 days, they're likely to have a section, what we call section 75, and then sort of have a review as if they're looked after children. And children stay in hospital for all kinds of reasons, don't they? Then there's independent, semi-independent living for our 16s and plus, which they'll come with very different complex issues, and you're likely to see them into GP surgery and other secondary and primary care settings. And then that maybe this is not something until I was embedded with the looked after, is children that are looked after can be in care of their own parents. We know that they can be in care of family members, and that's usually preferred to go to a family member and having a support network. But there has been cases where children are in care of their own parents. And there's also situations that shouldn't happen, but we know do, that children are placed in what we say is unregulated environments. So then they're not regulated, it's not an Ofsted provision. So therefore we have to notify Ofsted from a social care point of view, and that really adds some complexities to children. So these are the children that we'll be thinking about, that we're coming to face day in, day out, that we might not necessarily consider. That's really important. So putting it into context, and it is really difficult to talk about some of these issues when you're talking about children in care, especially when you're talking about people that foster children, people that work in care homes. We automatically, and rightly so, think it's an altruistic approach. You know, it's something that they're doing good for society, and absolutely the vast majority of our carers are people that are doing good and wanting to do the best for the children. That doesn't go to say that we shouldn't be naive to think that for whatever reason, children in care can still be at risk of harm. Now, before I started my career in looked after, I think I was a health visitor back in my previous life. I was a bit naive and thinking, breathing a sigh of relief, you know, oh, the children have been removed, they're going into a safe place, they've been removed because they've been subjected to abuse or neglect, and everything's going to be great in the world. When actually we know that children that are in care have the poorest outcomes, whether that's in health, education, employment, relationships, they do suffer the worst outcomes. So it's about thinking about that. And I think as a health visitor and then moving into the looked after world really struck me that I'd been quite naive to that. So there's been a study done, a long-term study done nationally around children in care that have been subjected to harm previously, and some learnings. This is just a bit of a framing around the complex case that I've been involved in. But and this brings it to home that there's 52 studies were published and reviewed, and we found that 39 reviews of children that were harmed were in foster care placements. That's 75% of those children. So while we might think of institutions and care homes, we must also think of those children that are coming to us that are in foster care placements or in placement with their family members. So it doesn't make a child immune to the fact that they could be subjected to harm or neglect. 19 of these children sadly died. Young children tend to die from physical abuse or severe neglect. Teenagers, it's more around their risk-taking behaviours or choosing to take their own life. There are lots of exploitations. Their vulnerability opens them up to lots of their conceptual safeguarding risks and the risks outside the family home as well. 79 children were seriously harmed, and a high proportion of those were sexually abused. 70.5% were less than 10 years old, and 62% were girls, which is really sends shivers, doesn't it, when you think about that suffering. And these children all have a right to recover from this harm. We need to recognise what's going on, and even if they're in a real positive environment, the harm they were subjected before they were placed into care can't be underestimated. And how do we support those children and young people to move on and actually try and make relationships in the future and build a family life for themselves? What was notable in all the reviews that have taken place is the children with disabilities were overrepresented as samples of those portion of children that had died at the hands of carers through the period time 2019. So putting it into sort of a bit closer to home, certainly closer to home for myself, is the high profile reviews that we have in institutional care. Now, you'll know that there's been some really high profile cases. You usually see them in national media, don't you? I think there was a case in Jersey. There's big institutional cases and things like that. But what happened to Doncaster in February 2021, at the sort of right in the middle of the pandemic, really struck us all, and has changed me professionally and personally significantly. It's been a big impact on the way I work and sort of my experiences, and sort of my in-depth knowledge and understanding around these group of children. So the complex abuse investigation was around the Hesley residential settings. So these are educational residential settings that's based in Doncaster, which you'll know Fullerton House and Wilsey Hall, for those that are aware of that more locally. And that's went on, and we've done a national review. So just to give you some idea of how that came about, was it was February 21, and I got a phone call saying that there'd been some whistleblowers around the Fullerton House and that children had been harmed. We alerted Ofsted, we did a complex case strategy meeting, and I don't think it prepared any of us for what we were to go in and see. So what that led to was about 3 weeks, 24/7 rolling visits from health and social care to go in and make sure that these children were kept safe, while we were able to work with their local authorities to be able to get them into a safe place. So we're talking around the national panel, although the numbers do increase and may have increased since. The national panel review talks about 108, and there's around 144 children that we know is associated to this abuse case. So we had to get a safe place for all those children. We had a deadline for Fullerton that was it, shut shop, but we had to also make sure they were safe throughout that time. So that was 24/7 child protection, medicals, and everything else we needed to support them. Now you'll see on the map there the red dots. The red dots are saying where the children come from. What is really striking for children that are in care homes is they're often moved far away from home, miles away from home, and that doesn't allow us as local authorities and local services to keep eyes on our children. So it makes it even more difficult. And if you can think about the pandemic was not a reason why this happened. The pandemic was it gave allowances for the organisation, for the facility to close down the doors, so people couldn't get in as easy. So people were viewing their children across screens. We don't know what their environment was like around them. It made it far more difficult for professionals and parents to get in to see their children, notwithstanding the distance, if you think about how we were in lockdown. But by no means is COVID a contributing factor to this. This happened when it would have done without COVID. So just to put it into sort of highlight some statistics around it, is we've got 144 children. Like I say, that does increase, and that's children and young people. So they did go up to around about 19. I think the eldest was 21. They're supposed to leave the setting and move on to a different setting as they become adults, but of course they were staying longer than they should have done. So we've got a scope. So we're looking at Operation Lima Alpha. Now that is the term that is the name of the investigation. So that's the police investigation. So we've got a complex case that we see that crime has been committed, and Operation Lima Alpha is the police operation that is still going live today and will do for some years. So we've got 13.8 years was the average age of children when placed into the setting, and 16.8 years when they left. Now, what happens with children when they go into care homes, and this is something we picked up with a work with the national panel, is they invariably they don't come out of their care home to go back home. They come out to go into an adult facility because they get too old. That has to stop. We have to prepare communities and children to go back into their home environment when they're not able to stay there, and how do we make it better for them to stay in the communities? So that was an issue as well for us. 3/4 of the children were boys, most commonly were white British, and the most common diagnosis was autism, 82%, learning disabilities, global development delay, and ADHD. There was a high percentage of children were non-verbal. So we're talking extremely complex children, the most vulnerable and complex children we could say for our that we have in society for us. So that has to be remembered. So that just shows really the level of the issue we had. So what in Doncaster we were working, we cleared out the care homes, and then it was about, right, what is the child's story? How do we bring this investigation to life? How do we work with the local authorities? Because I'm a health representative. So how do I support to be able to bring justice for these children? And how do we learn as well nationally? So I think what we need to do, we then come together and said there needs to be a national learning here, there needs to be a national inquiry, and we then put it to the national panel. So you may have heard in training that there's the national safeguarding panel. Now we did a rapid review and we suggested that it had national significance because of all the local authorities that were in place, and it had national significance. So we asked them to do a national review. We weren't sure whether they would take that up because the national panel had never done one of this size. They're relatively new, and they're usually single children investigations or a couple of children's and themes, but never of this scale that we'd asked them to do. So it was well, I think the right decision. They took that on. I don't know what we'd have done if they hadn't. We did have other things about what we might do, how we will get this into the sort of spotlight and how will we learn from it. But the national panel took it on. And I think what they did for us, they commissioned Dame Christine Lenihan, who's a very high influence, national influencer for children with disabilities and an advocate of that. And she was absolutely pivotal in the learning and the report that we've got since. So they proposed they would do the review in 2 phases. So this is where we get the learning from. Sorry. So the national panel in October 2022, they published their first. Now, at the end of the presentation, which I think you should all have access to slides, is there'll be the links to the reports. So if you want to read the reports and do some extra reading around it, it may be of value to you. So in October 2022, they came up with the findings. So this was the phase 1 report. They looked into it. They linked in with professionals, surrounding professionals, and everybody they could, and also the life stories of the children. The national panel weren't allowed to approach the families or children because of the live investigation. So we worked around that, and we worked very closely in Doncaster with Dame Christine and the team to bring our voices in there and to help them shape the review. And what they found, which I think we all knew, that the children experienced sustained and significant abuse in that environment, and the children's voices were not heard. They found that it was an issue for these children that they were placed far away from home. If you look in Lots of areas across England and Wales, you will see children placed far away from home. We often talk about children with mental health and emotional health difficulties being placed in inpatient provision from health. That is no different from social care in terms of local authority and education. The providers out there, it's a provider's market, and we're having to search and search for the right places for these children, and they are very finite at the moment and have been for a while. It's a real challenge for children in care that have to be placed out of the family home. Some children were placed in the settings inappropriately, so what they would, for example, the setting would say, yes, we can give them therapeutic intervention. Yes, we can educate them. We can give them the full package. But what they were doing is seeing who they were with and how it was configured and what was the needs of the child. They were promising all kinds of therapeutic educational intervention that they could do as a single provider, which in itself is a real problem because you've only got so many eyes on that individual child or a number of children. That was the problem. They belonged to the organisation. Whereas what we learned is eyes need to be on the children, but they don't just need to be on the children. They need to be listening and hearing to the children's experience, voices, and also families. We spent a lot of time with experts by experience and family members and parents about how they feel, not the parents of Fullerton, but the parents of other children, just to get their views and to bring it into this review. There were significant weaknesses around compliance in terms of the regulation and Ofsted. There's significant learning for Ofsted, and I think that comes into the recommendations. The quality assurance processes. How did the local authority, who has statutory requirement to ensure the children were thriving in their environment, how did they make sure that happened? And when you've got 65 local authorities going into one setting and looking after their child, how did they connect the dots between each other? Who was talking to across the country? That was a gap. They weren't talking to each other. What was a common factor was Doncaster's LADO process, and that fell short. So what we know is since Doncaster's local authority have done they commissioned an independent review on this, and they've put recommendations in because that was a failing from a local perspective. So national regulatory arrangements, they weren't met, and also there was in-depth analysis done in terms of the children, but also we've got to think about the workforce as well. The workforce, the carers from the workforce, it's about how they were trained, capable and resilient to deal with compassion with these children in these areas. Now, it's not to say that every carer in these care homes, must be really clear, not every carer in these care homes abused these children. It was a number of them that will be investigated, but there were good carers in there as well. So we can't say that all carers, but it's about, did they have the emotional intelligence to actually listen to the children and understand that any self-harm behaviour the children might have been exhibiting was their way of communication? Did they have the education training to be able to care for these children? So that's what we've learnt in phase 1, and what's also come out since then is phase 2 with a number of recommendations. But rather than going into that today, I want to sort of draw it into what it means for primary care, for GPs, for anybody working directly with children, for hospitals or anybody working. What does it mean to you guys in primary care? Now, I think what is worth mentioning just before I go on to this is that phase 2 of the reports, the recommendations of changes were That was published back in April 2023, and we are expecting the government response imminently. We are hoping that it will be coming at the end of November. We've met with DfE, we understand what the response is. We've just got to get ministerial approval to publish it. And as you can imagine, it's not always easy to find a slot to put this publication in when there's so much else going on in the world and in domestic policy as well as international and foreign policy. So we have to find a slot in order to put this out there. So that's the work that we're doing in the background. So you'll hopefully hear it in the spotlight again in the coming month or so. So how do we look at providing the care for these children in primary care? We need to provide a supportive, caring environment. We need to have in mind their past experience and also present experience. And if we get a difficult child, this is all children, whether it be children that are in mainstream education, children that are 16 plus in further education, or children with absolute complex, challenging health difficulties or challenges or mental health. So the children that come through our surgeries, it's about spending that time and trying to really emphasize the emotional well-being of the child, regardless of what they're coming in for. It's about us having the patience and the time to offer a consistent and compassionate care. You know, if the building of relationships for these children is absolutely fundamental. You know, they will be coming with attachment issues, with trust issues, with previous abandonment. This is all putting into play of how they are presenting themselves to yourselves and to others, and that challenge. So it's about trying to foster a relationship, which we know is not easy in the environment that we're working now. We're working in a really high pressure environment across primary care, secondary care. It's not going to get easier over winter. Part of my role is a deputy chief nurse, and I know how it's feeling out there. I quality manage the primary care over at Doncaster, and I get how it feels. So so this is nothing more than what you'd be trying to do as a practitioner, and fostering the relationship and really keeping in mind that what is happening for this child, what is it they're trying to tell us through their behaviours and through the behaviours reported by the carer, not always taking on face value what the carer is saying, having opportunity to sit with the child and young person and ask them what it's feeling like in their world, and really sort of read between the lines and understand their communication more than what they are actually saying, and more than the written word. So it's about supporting children in meaningful contacts, assessments, interventions, bringing them back again if they need to. If we need to explore further around their issues, bringing them back and taking the time to know that they may not tell their story in one consultation or more. And it's developing that sensitive approach to the therapeutic relationship that you and GPs, nurses, social workers must work hard to achieve with these children. Understanding the journey, always have in mind this children, especially, you know, young people, when they're struggling, may come with some real challenging, the behaviours that feel challenging and difficult, but usually if you explore deep in there, you can see that there's something else. Now I can see there's some hands up. I don't know if people want to stop and ask questions or whether or not we want to wait.
Thanks, Andrea. I can't actually see any hands myself, but
Okay.
Has anybody got any questions they want to ask Andrea at the moment?
I've seen a couple of hands fly up. Unless they've gone down now, they've gone shy. feel free to put your hand up and shout and ask a question. We've got 10 minutes. We're coming to the end of it. I'm happy to engage in a conversation, so please feel free to fire some questions at me. So it's recognising. Oh, hi. Do you want to come in? Is that Leanne?
Yeah, I'll pitch in on here. I'll declare a certain interest here in that. I actually went and looked at the Hesley group as a care home possibility for my daughter when I was looking at adult, you know, the later care.
Yes.
When she was moving into care, and I rejected it because it was too far away and too institutionalized feeling to me. But I think there was quite a lot of noise well before this inquiry went on, because I know I got directed away from there by people perhaps a little bit in the know in advance, which is a bit worrying, isn't it? And scary that it didn't all come to sight a bit quicker. But also I'm just thinking in terms of continuity, and as a GP, we rely very heavily on the person who attends any of our sessions with the person to tell us what's going on in the home. So it's very, very difficult to do that unless you've got someone who knows the patient well, and often that doesn't happen. So it would be better really to have a LES for these bigger homes attached to a practice, so that they could do some training on how to and have more time to actually build a relationship with these people, because my daughter wouldn't even give you the time of day unless she's known you for a bit.
No, exactly.
And that's the case with all of the patients that I deal with, that they have to build a sense of understanding with you, and sometimes that takes a long time if they're non-verbal.
Yes.
So
yeah. And that's absolutely.
I'll be watching with interest to see what happens.
Yeah, please do. And you're absolutely right. There are things we're sort of looking at, and it's good to think back in retrospect. And you know, the communities have been very vocal about what they knew about what they believed was happening in the care homes. So with hindsight, it's easy for us to say, but I think there are lessons. I think there are things that Doncaster Lado have learned and have changed since. So I think that's something. Sorry, we've got a baby in there. Oh, that's cute. Yeah, somebody's got a baby on there. Sorry, it's distracting me.
Can we just ask everyone to mute, please?
It's all right. Yeah, so I think there are things that we need to look at, and like you say, hindsight's a good thing, but I think it is really clear that the information, if they'd have been shared collectively, could we have intervened early? These are the questions we sit with ourselves day in, day out, especially when we've witnessed what we've witnessed since. So I absolutely take what you're saying on board with that. I think you're right about taking time to build that relationship. That's exactly it. And I know we sort of, I guess, especially with the children with complex needs and with non-verbal, having the carer there is fundamental, but I'd also look beyond the carer, because the carers were taking these children to local hospitals around the South Yorkshire region, and I think that gave a false sense of security to our hospital staff, in that they're with the carers, they're with the professionals, so we need to take the carers' word for it. So it's just being open-minded to the fact that if the carer is saying something but it doesn't connect with what you're seeing in front of you, just be curious and explore that. And you're right, it's about how we find our time to really understand the person in front of us, and that accounts for all our patients, doesn't it? So I think that's really important message that you send there, and I absolutely agree there should be accompanying when we've got complexities. We're talking about a young person that's 14, 15 in a foster care placement, with no additional needs. I think it's very important that that individual has the power and is empowered to speak for themselves, and to be on and to be open to you and have time on a one-to-one with you to be able to say how they truly think. And it's about using all our interpersonal skills, which we know we've got, because that's you know, we're in the profession of that, and it's part of you know, the daily work that we do, so it's challenging all that. So for me, it's around gathering that information, what we're seeing, looking beyond the spoken words, whether that be of the individual or the carer. Is it matching with what you're seeing, or is there something that's your intuition's telling you is not quite right? Following our intuitions as professionals. So aiming for continuous care, building trust is all what I've talked about, listening harder to the voice of the child, making sure that the children in need of mental health support are heard and they receive the care at the right time, the referrals, and how we can use our multi-agency rounders, be it social care, mental health services, or education, to support that child. We're all part of that child's package of support, and it shouldn't be pigeonholed to if the child's got mental health concerns, they can be supported by a full network of people. And how we ensure gaps of information. I dread when I think about what has happened, and I think how if I'd only connected the dots earlier, what you're saying is absolutely true. You know, the dots should have been connected, and it is recognised in the recommendations of phase 2 of how we might do that. And that's about quality assurance of placements and holding us all to account. I think we're going to get, from an ICB point of view, I think we're going to get some directions around how we engage with the quality assurance process of care homes, because at the moment it's statute to local authority, but how do the ICB become part of that, especially where we've got children that are CHC. Ruth, do you want to come in? Have you got a question? I just saw your hand up. I think it was Ruth.
Hi, can you hear me?
I can now, yes.
Thank you. I was just wanting to support the last GP. Sorry, I didn't catch your name. I think, gosh, how would I have known? I mean, yes, if we'd seen physical signs, but I bet you they wouldn't have brought them to us if they were physical signs to see. So just a feedback to stop this happening. If you have a surgery, and there has to be funding, as we have with sort of dementia care homes to go with that, and that we get to know the staff. We get to know, we build a relationship with these sort of children. The complex ones, particularly at standard care homes, it's less of an issue. But if they're non-verbal, sorry, it was just my.
I know, and I agree. I agree completely, and it's around that if we have got that in place, how do we support the GP that's in that surrounding area to do it differently? Like you say, how do we support them to go into the care home rather than asking the children to come and visit them, see them in their environment? How do we use our looked after nurses that go in? So hold that thought, Ruth, because this is all things of the recommendations. So there's additional work that I started regionally with NHS England, supported by the national team, about how we implement recommendations and the ideas around that. So these are little nuggets that I want to discuss and take in. And we've also got to remember that children with foster carers will be distributed throughout the area. I'm mindful that we're almost coming to 10-2, but does Sarah want to come in?
This is about children who are in sort of either smaller sort of foster care homes or individuals. Cross border, if they're from one area and they need mental health services and they're in our area, who's actually responsible for that? We have this every time. It's not our responsibility because they're from Derbyshire. It's not our responsibility if they're in Sheffield, and Sheffield says not our responsibility if they're in Derbyshire because they're Derbyshire looked after. Who actually is responsible for their mental health care?
So when it comes to
the GP,
when it comes to children, it's where the children is. So the responsibility. So where they're placed is where they provide the care, but the money, which is our concern at an ICB, comes from the authority from which they reside. So if I had a Doncaster child in Sheffield, I'd be looking to Sheffield's CAMS service to provide it, but we'd be paying from Doncaster, so they'd be invoicing us. So that's where so what happens, which is really a challenge for us, and children move too frequently, we need them to move less. It's about sustaining placements is best for the child, because we get them settled, we get them the care they need, and then move on. We get them settled, get care, and then move on. And placements, they can have silly amounts of placements in their time in care. Now, for me, I think it's around getting them settled and understanding the needs. And then now what happens in social care is the Doncaster social worker will stay with that child, whether they're in Doncaster or Liverpool or London, and they have to travel to visit that child in that placement. So that, given the complexities of all the cases and everything they've got on, is difficult. They're far away. Also, mum and dad might be in Doncaster and they've got to travel. It's exactly as we feel it, because I know we'll feel it in the inpatients care for mental health. So that's the scenario. And you're absolutely right, Sarah. It absolutely adds to the challenges and complexities we've got. But it's an ICB discussion about who's responsible for paying. Now, mindful that I've hit my time, and I did promise that I wouldn't go over. So I think if you're worried about it, share your concerns, follow your local guidance, follow your local LADO guidance, and speak to one of your designated name GPs or your designated team as well. Name nurses that come with specialist nurses that's local to your area. So talk about your concerns. And most of all, so to thinking to 21, 22, I've had 2 years of this investigation. Like I said at the beginning, it's impacted on how I work professionally and also personally. And it's about how I've sort of helped shape, I'm designated nurse from Doncaster that's helping shape recommendations that hopefully will change the future for our children. And that would be something quite special out of a really horrific situation and experience for everybody involved. And I think the point that we need to make is we work in true collaboration. We keep partnership as essential, regular communication, information sharing at all levels within our organisation is key, and remain true to your professional values and trust in your own integrity and transparency. You can't go wrong if you follow your values and what it means for you, and trust system change on a national level, that we can make a difference. Even if it's a local level, we can make system change no matter how big it is. You can be that voice for the kids that are coming in, not just on that visit when they come in. But I think a couple of you have spoke today, and you've really spoke, and you've articulated it really well, the challenges we've got. Things like this can influence how we work in the future, so please keep talking about it. And I've left my email, so if anybody has got a real interest in it and wants a conversation and be part of a network that I'm wanting to build up in terms of professionals and how to be a stronger voice, please get in touch with me on that email address, and there are the documents you'll be able to find that link to the national panel. So I hope that's been of value to you and of interest, and I hope you've got some learning out of that. It's gone really fast, 40 minutes, who'd have known? But thank you for listening, and thank you for the questions as well.
Thanks, Andrea. Thanks for that. Really interesting, and